Wonderful. All right, fantastic. Thank you everyone for joining Peppy. It is 12:30 Eastern time, so I think we'll get started. We actually have a lot to talk about today. Today we're going to have a roundtable discussion about vaccines where we focus specifically on vaccines for patients with primary immune disorders. So while this is a massive topic and we could certainly spend 2, 3, 4 hours discussing it, we're going to distill our focus down to a series of just kind of high yield questions that you may have. As everyone knows, this is Project PEPI, Project ECHO for primary immune disorders, where we focus on principally on education and free case consultation for rural primary care colleagues who may be experiencing patients with PI, evaluating them and working them up as well as managing them. So I'm just going to first poll the audience. We do have several folks here. Does anyone have any specific questions about patients with PI as it pertains to vaccine? And if you don't, we are prepared to walk through a number of different topics that we think would be interesting to you. However, we do not want to presuppose that we know what's interesting to you. So I wanted to first ask you if you had any questions. Okay. Please do feel welcome, however, and I'm going to ask my colleagues to introduce themselves. I'll introduce myself as well. But as Dr. Lawrence, Dr. Borish, and I discuss vaccines for primary immune deficiency patients, if we don't cover a topic you think is of interest, please don't hesitate to raise your hand, interrupt us, put a question into the chat. We'll be monitoring that. And again, while we could talk for a very long time, we are going to spend about the next 25 minutes. So as you know, my name is Nick Ryder. I'm a clinical immunologist. I work at Virginia Tech Carilion School of Medicine in Roanoke, Virginia, and I'm one of the faculty of PEPI here. Dr. Borish, would you like to go next? In alphabetical order, I guess.
Larry Borish. I'm a clinical immunologist at the University of Virginia. Monica?
I'm not sure how that's alphabetical, but okay.
B. Borish.
I just remember if we ever got married, I would be Larry Lawrence.
I was just using last names. Sorry.
I'm teasing. No. Okay. Monica Lawrence. I am also at the University of Virginia. I'm a clinical immunologist as well who sees both adults and children with immune deficiency.
And just to share a little bit about what we would like to maybe cover today, hopefully you're seeing my screen here. Can everyone see that? I'm not going to make a presenter view just because I think it kind of messes things up when you're using multiple monitors. But we would like to focus on these questions for today. And again, please do raise your hand if you have any questions or if you had other topics that you would want to discuss. So the first question often we get is, can patients with primary immune disorders be vaccinated? And, what scenarios would really kind of warrant vaccine avoidance? I mean, I think we are all proponents of vaccination, but we understand that vaccines can certainly do harm in certain vulnerable populations. So I think, that's a question that is of importance. So Dr. Borish, Dr. Lawrence, any thoughts on this?
I'll kick off because that way I get to do the easy part, and then Monica can jump in and correct me with all the more complicated thing. The conventional teaching always is, and a good starting place is avoid live vaccines. After I'm done, we'll go on a case-by-case basis on how to interpret that. But the one thing you're really scared about, and it's really, especially an issue with combined immune deficiencies, is that there are certain vaccines like BCG is the classic example, where in the old days, before we did newborn screening, infants, and in countries where they were doing BCG vaccine, one of the presenting things was life-threatening, often fatal, disseminated BCG in an infant who had no T or B cell immunity. So it's always good to at least think about the live vaccines and maybe reach out for a friend, because the other thing I really want is for our patients to have a normal lifestyle. So I've had patients who desperately want to travel to, the source of the Nile or go up the Amazon and then reach out to me. Is it okay if I get whatever? And we can talk about some of the specific ones. And my answer is almost always, here's the way to make it possible. But in general, point number one is if it's not live, it's almost certainly going to be safe. A lot of the immune deficiencies we see, especially in the adult side, are humoral immune deficiencies. And one of the things a related question is, what's the point of giving a vaccine to someone who's immune deficient? And again, in the case of humoral immune deficiency, the important thing to keep in mind is that by and large, the cellular side is working very well in those patients. And especially things like influenza or RSV, there's no reason to think that the CD8 response will be inadequate, and those vaccines should be specifically encouraged in those patients. And I have a lot more to say, but I'm going to let Monica jump in and correct me.
No, I think we started with a relatively non-controversial one. I agree with you, Dr. Borish. If I were a PCP caring for an immune deficient patient, I think any inactivated vaccine could be considered safe, and any live vaccine warrants a question of, is this safe or not? There's many conditions where I would say it is probably fine to give the live vaccine, but there's a handful where it's not. And so that would be a great kind of like checkpoint to just sort of say, hold on, let me stop and think about this. And in terms of how we think about it, if their T cells work normally and our normal number, they're probably going to be fine. If not, then you may end up with side effects or God forbid, vaccine strain infection. Dr. Ryder, what do you think?
Yeah, no, I think you both are spot on. I agree wholeheartedly. I mean, I think the virus or the vaccines we worry about in general are, as I said, the live viral vaccines. So kind of just to be explicit about that, you know, MMR, varicella, rotavirus, and then the live intranasal influenza vaccine are all vaccines we worry about giving directly to patients with certain types of primary immune disorders. You know, and then outside of the United States, BCG, as Dr. Borish mentioned, as well as yellow fever and smallpox are a couple of the other vaccines that we do worry about. So that set of vaccines are the ones that we think we always want to have paused. There is some nuance here in that, you know, as Dr. Borish and Dr. Lawrence mentioned, you know, patients with antibody deficiency, we don't know if the vaccine is going to work. There is some evidence that they will. We'll talk a little bit about that later. But our first concern is doing no harm. And, you know, the patients with T cell deficiency, so the patients, thankfully, now that we identify the vast majority of via newborn screening, via the TREC assay that every newborn in the United States, now in all states of the United States, is assessed for these T cell deficiencies. So if a patient were to have an abnormal newborn screen, really for any reason, but for our purposes, the SCIG newborn screen or the TREC newborn screen, those individuals who have an abnormal newborn screen, really, you want to think very, very carefully about giving any live viral vaccine to them. And of course, consulting your friendly neighborhood immunologist is helpful. And as Peppy, we're part of that. We're here for you if you have any questions about that. So, you know, the patients with SCID or euthymia or other forms of T cell deficiency that are picked up by the newborn screen, we worry about. So, yeah, agree wholeheartedly. You know, I'm going to try and make sure that this PowerPoint slide is as large as possible, but if you can't read that, please just let me know. It's a little bit of a pain to put it in slideshow view, so I'm not going to do that because I'm working with multiple monitors. So, but if you can't see that, let me know. So then we've got a number of other questions here. You know, the first question is, okay, you're telling me that my patient has a primary immune disorder, so why would I even vaccinate them? I mean, does this make sense? You know, if they can't mount a response, you know, is this a waste of time? You know, we think about risk benefit. Maybe the risk is very low, but in a patient for whom the benefit is extremely low, does it even make sense to do vaccination? And I think, you know, we'll talk a little bit more about it in question 3, but COVID has taught us a lot about vaccines and the vaccine efficacy for patients with primary immune disorders. So, you know, kind of we'll open up the floor here as well for thoughts about this, and, you know, ask my colleagues, and I'm happy to also respond. Do you vaccinate your patients with primary immune disorder, and do you feel that it's effective, and what evidence is there for that?
Mm-hmm. Yeah, one of the things I'm often asked is, if you're on antibody replacement therapy, is there really a need for vaccination since you're getting all these antibodies? We can specifically discuss the common encapsulated bacteria, like the pneumococcal vaccine or the Haemophilus vaccine. I don't actually specifically encourage those because you're getting immunoglobulin from literally thousands of donors who have all been vaccinated. And I think the recipients of immunoglobulin replacement therapy have some of the highest antibody titers you can measure to encapsulated bacteria. But one thing that's important to appreciate is the process of how immunoglobulin is prepared for administration. And it involves things like collecting the serum from these healthy donors, pasteurizing it, ultrafiltering it. But even after that, what makes immunoglobulin incredibly safe is that the process of purifying it takes a long time, but actually the serum is quarantined for a while, and it's only put out in the public until we know that the donors are still disease-free, that they're free of HIV or hepatitis or something like that. So there's typically about a 9-month gap between the time the immunoglobulin is taken from the donors to the time it's administered in the clinic, which means, as I joke, not a funny joke, with patients, you're completely protected from last year's influenza epidemic or last year's rhinovirus, but you're not getting antibodies to this year's. This is something we saw during the COVID pandemic, where Dr. Lawrence and I think we're routinely screening patients to see when the anti-spike antibodies would start appearing in our recipient samples relative to when vaccination was introduced. And again, it was about that 9-month to 1-year gap. And we'll get to more of this in some of the later questions. But for these reasons, I really encourage getting vaccinated to respiratory viruses because they're not being protected from that. And again, if the CD8 cells work, then a flu vaccine is probably doing some benefit.
Dr. Lawrence, anything you wanted to add to that? I agree. Dr. Borsch, wholeheartedly.
No, I think Dr. Borsch and I have a similar practice. And I just want to make sure everyone in the audience kind of understands what we're saying here, which is that even if you can't make an antibody response to a vaccine, which is often what we check, right? We'll check antibody titers, and that's often why we're treating people or diagnosing them with immune deficiency. They're cells of the immune system, the T cells, even in patients who completely lack the ability to make antibodies at all, so certain immune defects, they don't have B cells or they don't have antibodies at all, it's been shown that those patients' T cells do still respond to vaccines. And so that's one of the cool things we learned in COVID was that patients with those defects can make T cells and that they do get protection. So as long as it's not going to hurt them, my approach is there's a decent chance it's going to get some immune response. So there's a good argument to give the vaccine in general.
Agreed. I have nothing to add there. My colleagues are spot on. So I would only be like echoing everything they said. Thank you both. So kind of along those lines, I think, COVID disrupted so much, and in some ways it was helpful for, kind of understanding vulnerabilities in patients with primary immune disorders. I remember when the pandemic hit in early 2020, we were, as a community, very, very worried. I mean, we remain very worried, but we were even more concerned about our patients across the board with primary immune disorders, not understanding maybe how kind of differentially severe the virus would be based upon the type of primary immune disorder. And I know that one of the concerns we had early on was, this fact, as Dr. Boris mentioned, that, patients are on immunoglobulin replacement therapy, they're receiving IVIG or subcutaneous IG for an antibody deficiency, but they won't have any protection, in this blood product from SARS-CoV-2 because it was a novel pathogen. And then a couple of reports came out early on in the pandemic, like really within the first half of 2020, that suggested that patients with the most severe form of antibody deficiency, X-linked agammaglobulinemia, did not have severe outcomes. They got infected with the virus and they fought it off. And there were no real therapies at that time. And certainly there were no vaccinations. So that was a first eye-opener that maybe our patients, while we still were going to want to protect them and do everything we could to mitigate harm, might do okay, actually. It might not do quite as bad as we thought. But just at a high level, I'll kind of share a couple points about this. As was already related, not all PI are the same. And patients with severe T cell deficiencies, those, for example, who've had abnormal newborn screens or who are older and have been identified as having, a T cell deficiency, typically don't respond well to any vaccine. And they do have more severe outcomes to COVID. But thankfully, the individuals with antibody deficiency, by and large, as was already stated, do have responses to vaccination. And the COVID, pandemic really showed us. There was a study called COVID that looked at patients with autoimmune disease, and there were sub-analyses that looked at patients with PI. And they found that those individuals with PI did not have the same responses to the COVID vaccine to controls as we would expect. But that they did respond, and that 2 doses of, in this case, the mRNA vaccine, conferred protection to over 50% of those individuals with antibody deficiency, and that there was actually a difference between the 2 types of vaccines, and that the Pfizer-BioNTech vaccine was actually more effective in the COVID study compared to the AstraZeneca vaccine. So we're not here to necessarily advocate for any one company. This is just reporting scientific literature and evidence that's out there. So what we largely found is that the COVID vaccines were very well tolerated by patients with primary antibody deficiency or primary immune disorder. And that in a majority of patients, no matter, essentially depending upon the study you look at, patients with primary immune deficiency did actually respond to the COVID vaccine. Again, mostly because if they have a normal T cell response, they can get some protection through the vaccine along those lines. Any other thoughts, Dr. Borsch, Dr. Lawrence?
No, one of the remarkable things you just said was when we looked at people with bona fide, unambiguous antibody production deficiencies on IVIG who got the COVID vaccine. You gave a figure of over 50%, but I think figures go as high as 80% of those patients actually could make antibodies to the vaccine. And the quip I would say to a patient was, you may only have 6 functioning B cells left in your body, but they will respond to this vaccine, which is great news. But it also, and I don't know how far we want to go down this way, but it sort of points to the remarkable evolution in the vaccine development pharmaceutical industry. Historically, and I'm going back to Pasteur, the only way you could vaccinate somebody was with a live pathogen. If I inject pneumococcal protein or polysaccharide into a person, if I infect hepatitis B surface antigen to somebody, by itself, the immune system ignores it. The only way the immune system pays attention to a vaccine, and historically, was if it was live, ideally attenuated, and only with that sort of replicative infection would the immune system suddenly, to quote the famous line from Death of a Salesman, only then is attention must be paid. The magic is the use of these adjuvants, and the industry's really figured out how to mix these proteins or polysaccharides with adjuvants that really force the immune system to pay attention. But this is where we're going down that route of vaccine safety. The same adjuvants that cause the immune system to pay attention non-specifically do produce an immune response. And this is where people have gotten into trouble from vaccinations. They're not completely safe, but when they work incredibly well, and we don't have to use the live vaccines that we really want to avoid, and especially in our immune deficient patients. And I don't know if you, Nick, or Monica want to talk more about that, but the vaccines worked even in the immune deficient.
Yeah, no, I think that was one of the big eye openers for us, with COVID, because you had this novel pathogen, right, that we didn't know necessarily how it was going to act. We knew that the patients had no protection to it when they're immunoglobulin. So, Yeah, I mean, not to say that there aren't side effects of vaccines, but for sure in this population of patients who are incredibly vulnerable, depending on the PI that they have, one of the loud messages was that, vaccine improved outcomes in these patients and saved lives and was, generally very well tolerated. Dr. Lawrence, anything you wanted to add, or should we move to another question? Okay. Yeah. Yeah,
Do you
please.
want to, there's a couple of other people that have joined since we first opened. I don't know if we only have maybe 10 minutes left. If anybody has questions that have come up in their mind before we move through our list.
Yeah, absolutely. Great point. Please do feel free to raise your hand, put comments or questions into the chat. We wanted to make sure that we added value by discussing a number of maybe high yield questions, but we certainly, first and foremost want to make sure that any questions that folks in the audience have that we can answer would be kind of raised and addressed. So yeah, thank you. So I guess because we, and I think, we're all proponents of vaccine and vaccines and vaccination. But I think, kind of to that point, we might maybe want to jump down to one of the questions at the bottom of the list, because I think, there are caveats. I see Dr. Barroso has a quick question. Yes, sir. Before we jump down to
So I didn't want to disrupt your line of thought there, but real quick, I was wondering about like when you have not people who have PI, but people who have immune deficient state because, let's say, they just got done with chemotherapy, or they were on high dose steroids for more than 2 weeks for something. How long do we wait before we can then give shots? That I hope this isn't kind of neither here nor there. I hope this is the right time to ask that.
Yeah, it's a good question, because this really gets mostly to like secondary immunodeficiencies. So we do something to the patient, i.e. steroids or chemotherapy, unlike having a primary immune disorder where you've got a genetic defect that, you're largely not going to be able to correct completely, from all cells of the body. So, I mean, and I'm happy to take the initial stab and then, offer my colleagues as well rebuttal. So I would say
before you start, I'll do my favorite immunology joke. If you ask that question to 2 immunologists, you're going to get 3 or 4 different answers.
Very fair. Very fair. I mean, I think the distinction, and Dr. Barroso raises a great point, is that there's typically a predictable post-intervention response when someone's immune compromised due to a medication such as chemo or steroids. In the case of chemotherapy, where you're wiping out the vast majority of the immune system for usually a malignancy, but also for other reasons, if you don't have B cells or antibody producing cells, the likelihood that you're going to get a durable vaccine response is very low. So I'm not a transplanter by caveat, so nor do I give chemotherapy. So I'm speaking as someone who principally takes care of patients with primary immune disorders. But in the settings where I'm caring for patients post-transplant who have received chemotherapy for treatment of a primary immune disorder, we actually don't vaccinate those individuals until we start to see what we call the B cell compartment or the antibody producing cell compartment come back. And we monitor that serially by both checking native antibody production. So we look at IgG, IgA, and IgM to see when the patient starts to make and recover their own B cell function. And we actually look at the numbers of B cells in the peripheral blood. And once the patient starts to make antibody, and, again, to Dr. Borges' point, what would you consider normal? Most of us think, above 500, you're starting to get into the normal range, evidence of B cells kind of in the normal range in the blood. Then at that point in time, we start to vaccinate. And, usually that's not much before 12 months post-chemo. Usually you're 9 to 12 or more months down the line before you start to vaccinate. But those individuals who can't be vaccinated, we recommend putting them on immunoglobulin replacement therapy in that setting. I don't really withhold vaccines for patients who are on medications like steroids or immune modulators. I give them the vaccines according to the regular schedule. But I'll pass the baton on to my colleagues to see if they have any other thoughts.
Well, the caveat is it changes based on what the vaccine is. You can put off pneumococcal or even shingles vaccine for a year in someone who may be at intermediate risk, but for things like the current COVID serotype or this year's flu, you don't, if you're going to give it, you need to sort of give it now. And that might change your answer a little bit, yes. Nick?
Yeah, no, I mean, I didn't want to dominate the conversation. Dr. Lawrence said, no, if you had anything to add. If not, we could maybe address one more question before we.
No,
I
I agree with what you both said. So yeah, let's do the last one.
So I do think this number 7 is interesting because I think this gets to, we're not just saying indiscriminately give all vaccines and don't worry. We definitely have concerns, and there is quite a bit of nuance. So I think, one question that's great is, are there concerns for vaccinating household members of patients with PI? Any thoughts on that? Either Dr. Lawrence, Dr. Borish?
Well, historically, sorry, you go ahead. I'm talking too much.
No, it's okay.
Historically, this goes actually back to the early days of polio vaccination, when the vaccines were a live attenuated virus that had no risk whatsoever in a healthy person. But all of a sudden, we were just finding all of the household contact members who had an undiagnosed PID who actually subsequently developed severe polio complications and death from their household members. So part of this goes back to that question of being careful with the live vaccines.
Dr. Lawrence, you want to share?
Yeah, I mean, I think now, since we don't really use oral polio in the United States, I think polio is less of a concern. MMR is really not a concern. Chickenpox, if the person who's gotten vaccinated gets a rash, then in theory, the immune deficient patient shouldn't be in contact with that person's skin directly, right? So wanted to avoid that. And then I think the other time I worry is in infants of immune deficient patients who get rotavirus. It's a good excuse to get out of diaper changing. If you are an immune deficient patient or you have an immune deficient patient, you shouldn't change the diapers of a child who's been vaccinated with rotavirus. I think it's in the last 2 to 4 weeks. So kind of since they get the vaccine at 2, 4, and 6 months, it sort of gets you out of diaper changing duty for a long time. So
These are great. I really don't have anything to add except that, Dr. Lawrence's comments about, a rash in a family member who received varicella or in the infant who's received the oral rotaviral vaccine, and kind of diligent hand washing and so forth with diaper changes. Those are actually CDC recommendations. So, we're constantly revising thought, but this is kind of the overarching answer is, if you're caring for a patient with a primary immune disorder, by and large, with very, very few exceptions and just kind of simple, practical mitigation strategies, as was discussed, the family contacts can all get the vaccines that they need on the schedule as is recommended. So that gives a lot of comfort too, because some of the family members may have unique healthcare needs, even if they're not immunocompromised. So we want to make sure that they get the healthcare that they need as well. So I know we're coming up on the last minute. Any final thoughts, Dr. Lawrence, Dr. Borish, parting comments before we close the session?
I was just going to put in another word for the vaccine industry, but the old shingles vaccine was basically a little bit better than not getting vaccinated. But I just want to reemphasize how incredibly effective the industry has gotten. And Shingrix, I think the statistics are you can be in your 90s and that vaccine has like 98% efficacy. So they really know what they're doing, but that efficacy does come at a cost of potential side effects and flu, especially flu-like symptoms after the vaccine. But that's my last comment.
Great. Dr. Lawrence, if you didn't have anything, I'll just close us out. Thank you everyone for your time. We really appreciate your attendance. This is actually the last Peppy session for 2024, but please look for us in 2025. If you loved this session or we didn't get to a question that you wanted to have answered, please reach out to us. We're happy to respond asynchronously or do another session that's maybe a little bit longer in 2025 if you really loved it. So wishing everyone the happiest of holidays and a great new year. Thanks everyone.